As people are entering into our webinar session, I will just first do some housekeeping. So good morning, good afternoon, good evening to everybody. My name is Olive Copeman with the Network for Improving Quality of Care for Maternal, Newborn, Child Health. This webinar today, Transforming Care in Small and Sick Newborns, is part of a series that has been hosted by World Health Organization and UNICEF with the Every Newborn Partnership. Next slide, Rosie. So this series accompanies the learning and experience in implementing WHO standards for improving the quality of care for small and sick newborns in health facilities. These standards were published in 2020. And so as work is progressing in earnest and related guidance for their implementation is taking action in countries, we're presenting a series of webinars over the course of this year. So the next webinar will be on August 25th, where we will share the thematic brief on nurturing care for every newborn. So this is a new brief being launched by WHO and partners, and the findings that are being presented today are very complementary to that brief. Next slide, Rosie. So today's session will have two parts. At first, we will have the presentation and the panel discussion on the immediate KMC, how it improves survival of low birth weight infants. The presentation was made by Dr. Rajiv Pal, Newborn Unit Head and Head of Research at Department of Maternal, Newborn, Child and Adolescent Health and Aging, with WHO and Geneva. We have a great bunch of panelists, part of the study team, and in one moment, Rajiv will introduce the team. The second part of today's session is questions and answers. And in this moment, we want to hear from you. Please post your questions in the chat box. And in the second part of the session, the panelists and Rajiv will respond to those. So over to you, Rajiv.
Thank you very much, Olive. And just to check, I couldn't hear you very well, but can you guys hear me? Olive?
Yes, I can hear you.
Yeah, we can hear you, Rajiv.
Yes, we can hear you.
Perfect. Thank you very much. And welcome to this webinar. As Olive said, I have the pleasure to introduce the panel, and I would like the panelists, as I speak about them, to please put on their videos if they can. The first panelist will be Professor Harish Chelani from India. He is a professor of pediatrics in Safdarjung Hospital and Vardhaman Mahavir Medical College. And he was one of the principal investigators of this study from the India side. The second panelist will be Dr. Helga Naburi. And Helga is a pediatrician at Muhimbili University of Health and Allied Science, Tanzania. And she was one of the principal investigators of the same study from Tanzania. The third participant, I'm not sure if she has been able to join, was supposed to be Dr. Jikwa Plonge-Rule. She is a senior lecturer in the Department of Child Health at Komfo and Enokie Teaching Hospital in Ghana. But I think, unfortunately, she is not able to join today. She's one of the principal investigators from Ghana. Dr. Kondwani Kawaza is the next panelist. He is a pediatrician and lecturer at the College of Medicine in the University of Malawi in Blantyre. And he was one of the principal investigators from the Malawi side. The second last panelist is Dr. Ebun Adjugebi, and she is a professor of pediatrics at the Obafemi Awolowo University, Ile-Ife, Nigeria. The last but not the least is Dr. Nils Bergman, who is a researcher and a long-term KMC expert working currently at the Department of Women's and Children Health in Karolinska Institute, Sweden. But he has many other settings and mainly has worked in South Africa, Zimbabwe, etc. So that is the panel. I will continue and bring the panel back after the initial presentation. The presentation that we have for you is the new evidence on KMC, which is on immediate KMC, starting KMC immediately after birth, improves survival of low birth weight infants. This is the study team. As I had said, there are 5 sites: India, Ghana, Nigeria, Tanzania, and Malawi, each represented on the panel by at least one of the principal investigators. And you can see the others here. 2 supporting units, one from Sweden and Norway, which is represented by Nils today, provided the support for intervention. And the overall coordination and support to the study was done by the WHO. Just to briefly tell you very, very briefly about the burden of low birth weight, about 20 million or 15% of all births are low birth weight, most of whom are in low and middle income countries. But interestingly and importantly, these 15% babies contribute to about 70 to 80% of all neonatal deaths. So that's where the importance of this low birth weight group is. But not only survival, low birth weight infants are also at an increased risk of early growth retardation and developmental delay. Current guidelines on kangaroo mother care from WHO are that it is recommended for babies born in health facilities or who are in the health facilities for routine care, and these are for babies less than 2,000 grams at birth. While there are brief sessions of KMC initiated when the condition of the baby begins to stabilize, the continuous KMC is only recommended when the baby is clinically stable. Why are we recommending kangaroo mother care? And we have been doing that for the past 20 years or so, is because of the evidence that KMC is associated with a 40% reduction in neonatal mortality, but also substantial reductions in sepsis, hypothermia, hypoglycemia, hospital readmission, and improvements in exclusive breastfeeding and growth, and also neurodevelopment. So what was the rationale for the study that we are going to talk to you about? That the previous studies, I told you that there was a 40% reduction, but were all conducted in children, started pretty late. The mean age of randomization of the studies included in the Cochrane review was about 3 days, ranging from earliest of 10 hours and latest to 25 days in the 8 studies that exist. So what is the problem with that? The problem with that is that half of the preterm deaths actually occur in the first 24 hours and 3/4 in the first week. So by 3 days on an average, 2/3 of the babies would have died, or majority, at least the majority of babies would have died by the time KMC can be initiated as per current guidelines. So what we did not know is, does continuous KMC initiated immediately after birth without waiting for the babies to become stable, compared with the current guidelines, improve neonatal survival? And why were we confident that we could do this and this was reasonably safe? Was because of 2 smaller studies in Vietnam and South Africa, both of which involved Nils, had shown that skin-to-skin care started immediately after birth was safe, but also helped low birth weight babies actually stabilize faster. So there was no reason to wait until stabilization. So what was the design of this study? It was a randomized controlled trial, which was multi-country, multi-center. As I told you, the 5 countries, these were tertiary care or referral hospitals in these 5 countries. The population was babies who were in the newborn intensive care unit. And these were selected as babies with birth weight between 1 kilo and 1.8 kilo. Why not below 1 kilo? Because most of the sites or many of the sites did not provide adequate or full care to babies below 1 kilo for survival, and 1.8 kilos because that was the upper limit in some of the countries for babies to be mandatorily in the newborn care unit. The intervention was KMC initiated as soon as possible after birth by the mother or the surrogate. And the control was not no KMC. Control was also KMC, but KMC initiated only after the baby was becoming stable, and then continuous KMC only after baby was fully stable. One other important thing to note here is that the both groups, intervention and control, received WHO minimum package of care for small babies, including respiratory support with CPAP. So all the other interventions were done as part of the co-interventions in both the groups. The only difference being the following. In the intervention group, continuous KMC was started as soon as possible after birth. The baby was kept in what we will explain a little bit called MNICU or Mother NICU. And throughout the stay in Mother NICU, the baby continued to have KMC as long as possible during the whole day, 24/7. And once the baby was stable, the baby was moved to a KMC ward, and continuous KMC was continued or was sustained during hospital stay in the KMC ward, but also after the baby was discharged home. The difference was in the control group, the only difference was that initially the baby received care in a warmer or an incubator in a newborn intensive care unit, and the baby was not started within the NICU on KMC unless the baby started recovering, where brief sessions of KMC were done as per the current WHO guidelines, but only after the baby was shifted out to the KMC ward was continuous KMC started. Inclusion criteria were very broad, including the birth weight I told you, 1 to 1.8 kg, but it included twins and babies born with cesarean section, which are where it is more difficult to provide KMC, but for generalizability, we included these babies in the study. You can see a few exclusion criteria when mother was unable or refused to provide consent, where there was such maternal complications that mother would not be available to provide skin-to-skin contact for at least first 3 days of life, triplets or quadruplets, babies, newborns who were unable to breathe spontaneously even after 1 hour of birth, after resuscitation, which meant that they were at a very high risk of death in the first few hours of birth, were not included. And so were major congenital malformations, and also babies who resided outside the study area because we wanted to do a 28-day follow-up for neonatal mortality and also include them in a follow-on study, which is on neurodevelopment. The three main components of the intervention were continuous skin-to-skin contact with the mother or surrogate starting within 2 hours of birth, aiming for more than 20 hours a day. Counseling and support for exclusive breast milk feeding and early breastfeeding, or putting the baby to the breast as soon as possible. And the third important issue is that all the required medical care for the mother as well as for the baby was provided in skin-to-skin contact without separation as much as possible. So that was the major difference. The mother was within the NICU with the baby. And this is where what the MNICU or Mother NICU looks like. You can see two pictures, one from India and one from Tanzania. You can see the mother with her baby providing skin-to-skin contact, while other care is provided to the baby and to the mother as per the current practice. You can also, in India and Tanzania, there was slight difference. Panelists will talk about it. They managed to create a new unit. Whereas in Malawi, Ghana, and Nigeria, half of the space for small babies was converted into the mother NICU, whereas the other half remained as the conventional care in the NICU. You can see in Ghana, in that picture on the right, upper right, that there is one half behind the wall. You can see the mother with her baby, and on the right side you can see incubators, in which babies were kept in the incubators until stabilization. In Nigeria, there were 4 rooms which were converted into mother NICUs, and just up on the opposite side, which unfortunately is not shown on the slide, on the picture, were the babies in conventional care. So just to tell you a little bit more about the MNICU, everything related to the care of the newborn was available in the MNICU. So here is a picture from India, and you can see the various things. The warmer, where if the baby and mother were for some reason separated, the baby could be kept in the warmer when the baby was not in skin-to-skin contact. The monitor, which was basically a pulse oximeter, where you could see the SpO2 and heart rate. You have the CPAP machine, which provided blended air and oxygen mixture, and CPAP with different settings of pressure. You have provision for IV fluids, oxygen. You have an adult bed in the NICU for the mother or the surrogate, with adjustable back support, because you would like the mother to be a little bit elevated when she is lying down. In addition, what you see there were additional areas alongside the NICU for hand hygiene, a pantry where the mothers could warm their food and have their food, a shower, and a toilet. So the provision of all care, including respiratory support, you can see a baby in Malawi getting oxygen support, and a baby in Nigeria getting CPAP support while in skin-to-skin contact. And which is important to note that we achieved about 17 hours of KMC per day in the MNICU while the baby was staying in the MNICU. In contrast, in the control arm also, there was KMC with the brief sessions of KMC, about 1.5 hours per day. Now, 1.5 hours is 1/10 of the time, but still, that's quite a lot. If you see what babies receive within MNICU, 1.5 hours a day while they stay there is, with current guidelines, is a lot. So the comparison was this continuous KMC with some small periods or brief sessions of KMC. So this is the control area. The babies were in different places in the control area as per the convention, some in incubators, some in warmers, others in open cots when they were they were getting to the stable condition until they were shifted out of the NICU. So the results of the study, quickly, all mothers and babies who were born in the hospitals were screened over that whole study period. There were about 80,000 infants born to about 77,000 mothers because of the twins, etc., of which 72,361 did not fit the weight criteria, and some were excluded because of the reasons shown. The most important of them were not able to provide consent because of the condition of the mother or some refusing consent, and also a relatively large number of babies who had such severe asphyxia, etc., that they did not breathe within 1 hour of birth or had severe malformations. Eventually, about 3,211 infants born to 2,944 mothers were randomized, 1,609 to the immediate KMC group and 1,602 to the conventional KMC group. Allocation was concealed until allocation by sealed envelopes. And then what we see here is what are the characteristics of these babies. You can see that they were randomized around 35 minutes after birth in both the groups. And birth weight average was about 1.5 kilos. Gestation was just less than 33 weeks on an average, equal number of males and females. And very importantly, about a quarter of babies who were twins and a little over a third of babies who delivered cesarean section. Importantly also, that about 45% of babies had respiratory distress. So they were provided CPAP in the immediate KMC group while on skin-to-skin contact, and in the other group, they were provided CPAP while they were in the warmer or incubator. The main findings of this study was recently published, I can say that, last month in the New England Journal of Medicine, and it showed that there was a 25% lower neonatal mortality rate in the intervention group compared to the conventional KMC group, with a p-value of less than or equal to 0.001, which was a stopping rule, and the DSMB stopped the study at about 80% recruitment. The death between enrollment and the first 72 hours was also similarly reduced, but did not reach statistical significance because of lower numbers. Also importantly, 35% lower hypothermia and 18% lower suspected sepsis in the intervention group. Other secondary outcomes were not very different between the groups, including exclusive breastfeeding at the end of the neonatal period. But what you note here is that after discharge from the NICU, when they went to the KMC ward, both the groups received about 20 to 21 hours of KMC per day, and they continued to do that at home in both the groups. And therefore, the exclusive breastfeeding rates are very high in both the groups. And they fully breastfed at the time of hospital discharge was relatively low in both the groups. So we didn't see much difference in these outcomes. Maternal depression seemed to be different, but was very low in numbers. So we didn't find it to be statistically significant. Additional breastfeeding outcomes. If you look at the initiation of breast milk feeds within the first day of life, or the infant being put to the breast within first 72 hours, or you just compare the age that the infant was first put to the breast, you will see that much earlier time of infant being put to the breast, started on breast milk feeds, etc. So there was a substantial difference in these additional outcomes. Another interesting piece of evidence is what were the causes of death and which causes were reduced in the KMC group. The most important one was sepsis, 36% reduction in sepsis or infection-related deaths, followed by none others were statistically significant, but perinatal asphyxia, other causes, and sudden death was lower in the intervention group. Where particularly important is the sudden death, because one of the things that is usually some people are scared of, and some of the investigators were scared of when they began the study, is that because of putting the baby in this skin-to-skin position, we should be looking for any increase in sudden deaths. If at all, we had a reduction in sudden deaths, although this difference is not statistically significant. So 3 conclusions from the studies, the slides that I presented. One is that immediate KMC reduced risk of neonatal death by about 25%. Now, if we look at these results in a different way, the absolute reduction in risk KMC would have to be provided to about 27 babies, and it would save one life. So if we were able to scale it up all across the low and middle income countries, it would be translating to at least 150,000 additional lives saved every year. The third conclusion is this MNICU, which was a byproduct of this study, where there was now no separation between the mother and the newborn. And just to say, when the mother was unavailable, it was a surrogate chosen by the mother who provided skin-to-skin care. And usually in these, unfortunately, in these hospitals, it could not be a male member or a father, or because the hospital policies did not include, did not allow use of or stay of males in these hospitals. So it was a chosen surrogate who was a female, a friend, a sister, a mother, mother-in-law of the woman. And this, although is a big paradigm shift in the care of low birth weight infants, so it actually takes the whole concept of family integrated care or family centered care to a very different level, where essentially you are not separating the mother and the baby at all. So I will stop here because I want to have some discussion with the panelists around different questions that we have, and then we will have the opportunity to discuss this with you and answer your questions as well. So this is the panel. I would really, I'll stop sharing the screen for a while and ask the panelists to please switch on their videos if possible. I have a few questions for you as you were the ones who were, either all of you were conducting the study or leading the team that was doing the studies. So my first question is for Professor Chalani, and maybe you can answer for your site and also for the other sites as well, just to save time. And the question is, how did you set up this new infrastructure of mother newborn care unit? How did you manage to do that in your hospital without using project funding for this infrastructure change? Over to you, Dr. Chalani.
Thanks, Dr. Rajiv. Since the intervention required the mother and baby to be kept 24/7, and there was no space available at two sites, India and Tanzania. So a separate infrastructure was created. But since the requirement was the mother and baby to be together, so other three sites, they managed in the existing nursery a separate place to keep the mother's bed inside. So that was the arrangement was done. But in all the sites, the support of Department of Obstetrics was taken because the space was created in the Department of Pediatrics place. And the hospital administration was also part, because a lot of, like in India, the 12-bedded new infrastructure was created. So the total funding was from the hospital budget. And we require separate the nursing people, the doctors and nurses. Doctors were, of course, from both the Department of Obstetrics and from the pediatrics, but the nurses were separately provided by our nursing superintendent, and support staff also was sanctioned separately by our administration. So the total funding was from the hospital budget. Yeah, over.
Thank you. I will move on and come back to some of you later. The second question is that it's not just the infrastructure. They also required a change in policies for mothers and babies to be together. It required the surrogate to be present. So what were these changes in hospital policies that you found were necessary in your site and the other sites? Dr. Helga, would you like to address that question?
Sure. So for many of our countries, there was a lot of policy change which was required because obstetrics and pediatrics are separate departments. And so we needed to convince the obstetric department to work together with us because the study involved making the obstetricians allow us to go to the delivery points in the labor ward and also in the theater when the baby was being born. Also, to involve the obstetrician to come and provide care to the mothers who are admitted in the ICU. And also the hospital to allow the mothers to sleep in the mother NICU because this was not a policy. And also to allow for the surrogates, except for Malawi, where guardians were allowed in the delivery space. In other countries, this was not really required as to convince the administration. So
what about
overall,
the food? What about the food and other things for the mother or surrogate? Were they also included as part of the care?
So for the mothers who are coming from other regions, they were getting food from the hospital, and other mothers were getting food from relatives, like other patients in the hospital. So the major policy change is that it resulted in zero separation, which was also translated in increased care in the stable Kangaroo Mother Care.
Rajiv, shall I come in for there was another change in the policy which was done with regard to the early shifting of the mothers who were delivered either vaginally or by cesarean section, because otherwise it takes for 12 hours to shift in the vaginal cases, and cesarean it was 24 to 48 hours. So we discussed with the obstetric group, so all the sites also agreed to shift them as early as possible, so that from surrogates, the baby was shifted to the moms.
So it leads me to my next question, which is that these mothers also then needed care in the NICU. So maybe Dr. Kondwani, could you just tell us about how these mothers were cared for, and what was the obstetrics neonatology collaboration and how was it achieved?
Thank you, Rajiv. We are really grateful because of the collaboration that occurred between ourselves as neonatal.
Kondwani, could you put on your video if possible?
The video is on. You can't see me?
Okay, we can't see you. We only see something black. Okay.
Okay.
Yeah, go ahead.
Yeah, so this study would not have succeeded without collaboration between pediatric experts and obstetric people. And we're really grateful for that. That was important because it was meant to ensure that the study procedures happen according to protocol, but also to ensure that care for both for the mother and the baby is also not compromised. So the collaboration really started right from the beginning. My colleagues have talked about the support we got from administration. We also got support from the obstetric departments. In fact, we incorporated all the obstetricians. We incorporated obstetricians right from the beginning. In all the sites, there was a PI at least from the obstetric department. And these people were involved right from the planning stages of the study, from protocol development, from development of SOPs for the study and also for care. There were teams that were identified on both pediatric side and obstetric side, just to make sure that people work together, right from identification and recruitment of mothers, care of the mother during delivery, and then transfer of the mother from delivery area to the NICU. And really, during the full period of the study, there were regular meetings between obstetrics and pediatrics to make sure that the study runs properly. So indeed, mothers were being cared for in NICU, and obstetricians, through our collaboration, were able to come to NICU to look after the mothers.
Kondwani, what about the nurses? What about the nursing care for the mothers? Who provided nursing care to the mothers when they were in the NICU?
Yes, so during the trainings, all nurses were trained on the study, both from pediatrics and obstetrics. And some of the care aspects for the simple monitoring for the mothers, the NICU nurses were able to do that. But for more advanced care, we were able to arrange that obstetric nurses and obstetric clinicians come to the NICU and look after the mothers. And this happened in almost all the study sites that were involved in the study. Thank you.
Thank you. Thank you very much. So my next question is for Ebun. What about how did the health workers take it? Did they like it? Were they afraid of this change? How did the mothers take it? Because were they happy to be with their babies, or did they find it to be difficult? So what light can you shed on this based on your experiences, which are not easy to put in a paper? But you can tell us a little bit about how the health workers and the mothers felt.
Yeah, thank you very much. So at the beginning, the health workers were very, very skeptical and apprehensive. In all the hospitals where the study was carried out, we are all used to KMC, but in stable babies, and usually a little bigger babies, these babies were less than with 1.8 kg and about 1 kg. So the losing these babies were fragile and with very fragile skin. So they were very scared that these babies might just die, you know, in the process of putting the baby on the chest. So initially they were, even though we had done a lot of training and advocacy and awareness, they still were apprehensive, both doctors and nurses. But after the first few cases and they saw that the babies survived, then they saw the benefits. I think one of the things that we assured most of the health workers was the use of monitors, the continuous monitors where the babies had on, and also that within a day or two, mothers or surrogates were able to handle the babies that they thought were so fragile. In fact, we're able to put the babies back in the KMC position. That was one thing that actually encouraged the nurses and the doctors and other health workers. And also, I would say that infection was one of the things that they feared most. That, you know, because NICU, we don't normally allow mothers to come in that often, relations, and then suddenly there's increase in traffic of people coming into the NICU. And the babies also staying on the mother's skin directly. They felt this would cause infections. But alas, that wasn't the case. The babies did better. Infection rate was lower in them. So they really saw that that was the benefit. And then it reduced even the workload of the nurses, particularly in many of, you know, not all the low income countries. We don't have enough staffs in the hospital. So these people were able to do this work faster because the mothers were feeding their babies themselves. Some could use Palata in India. Some could even use NG2 in Malawi, so they saw that this was helping. And not just that, the nurses also came to appreciate that the mothers are not what we think they are.
What about the mothers, Ebun?
Okay, the mothers themselves, initially they were very apprehensive too, because they felt that what they hear, what they know is incubators. Why this new experiment with their baby? But once they saw that other mothers were in the world doing it and the babies were doing better, they wanted it. And once they tried it, they felt, one of the mothers said, I feel as if the baby is right inside my uterus because of the contact I'm having with the baby, because of I feel the baby is breathing. I can actually say how the baby, is next, what is his pattern when he wants to eat, when he wakes up, which was a very good thing. And also, I will lastly say also that the surrogate themselves, they are happy to be part of, contributing to the survival of a relation's baby. So that was a good experience for everybody overall. Thank you.
Thank you, Ebun. In interest of time, I have two more questions, so I'm going to go quickly because we also have questions from the audience that we would like to address. So very quickly, Jikwa, I'm glad you have been able to join. And I have a question for you to start, and maybe others can chip in as well. Very quickly, what were the main challenges in implementing this intervention, according to you, in your NIC?
Okay, yeah, thank you very much, Rajiv. Yes, I've finally been able to join. So I think amongst the main challenges initially was getting the staff to accept the whole idea of putting these very tiny, very sick babies into skin to skin. And as Ebun mentioned, the presence of the monitors was a very big help in making people confident. We had quite a challenge. We had quite a number of challenges getting surrogates. So wherever the mother was for any reason not available, surrogates was often a big difficulty for us, because very often the very person who would act as a surrogate would be the same person who was running around sorting out various things for the mother. So we had a little bit of difficulty getting surrogates to initiate skin to skin. However, when they did come, I was amazed at how willing the surrogates actually were when they finally did arrive to take part in the skin to skin. Even fathers, we were surprised at the number of fathers who were happy to be on the ward in the midst of other women with their babies in skin to skin. Our hospitals do not consider the mothers of the babies as patients. So, issues like feeding them, whoever was doing skin to skin, feeding them. So later on, as we know, we had to support mothers with feeding. So that was a challenge, feeding.
Yeah, thank you. Thank you very much, Jikwa. I know there is a lot you want to, everybody can speak, but I'm trying to balance, and we wanted to finish the discussion, the panel discussion by 2:40. We are 2 minutes over. So I want to give the last 2 minutes to Nils to talk about your experiences in other settings beyond this study, in either other low middle income countries or even in high income countries in Norway and Sweden. What have been your thoughts and experiences that you have seen about this intervention? Over to you, Nils, for a couple of minutes, please.
Thank you. So my own experience goes back to a publication that is in 1994, where in a historic control, birth KMC, immediate KMC, produced exactly the same order of magnitude, 40% lowering of mortality, 25%, as also shown by Ornella, who's on our panel here also in the background, in Mozambique, not a randomized controlled trial at all, but an observation. And the one that is a randomized controlled trial is in Ethiopia by Bogale Worku and team. So sporadic spaces, nothing consistent, nothing programmed, examples of such things. Then the two randomized controlled trials you've seen the titles of. The second from Vietnam comes with a longer history of very intensive Kangaroo Mother Care done very early, and a program fairly nationwide that shows profound benefits of this. This randomized controlled trial is one of the studies. So the Africa, low income, middle income, South Africa. I now live in Sweden, where this preceded the work even in the 1960s, 70s, 80s, the research of mother-infant connection, mother-infant units, the couplet care. So there we had started also a sister study to the IKMC study called Epistos, where we wrote a very detailed standardized operating procedure, an SOP, which we also filmed. And that procedure from Karolinska Institute is indeed the platform basis of the intervention in the IKMC study. So this linkage from third world, low income, middle income, high income, it's a consistent whole of an intervention that is producing now in this really definitive outcome in the immediate KMC study, a 25% lowering of mortality from early immediate KMC. I'm happy to share in the chat the link to this training film, which is online and can be watched by all of you that are participating. Thank you, Rajiv.
Thank you very much. I'm going to go now to the audience questions. I'll start with a few. I will provide brief answers and I will answer some if I don't need to go to the panelists. The question was respiratory support. Was respiratory support provided while skin to skin, and was it difficult? Just as an answer, there was another question on mechanical ventilation. Most of the sites except India did not have mechanical ventilation. In Africa, none of the sites provided mechanical ventilation. And in India, while the babies were on mechanical ventilation, the skin to skin was interrupted. Just to say that. But very quickly, anything about respiratory support that one of you wants to talk about? Was it difficult to provide it well with CPAP? Chalani, can you start maybe quickly?
In fact, there was initial apprehension and, but once we got the support and training from the KI team, we were very confident, and then it was an easy thing. And now it has become a routine thing to provide CPAP and tube feeding while the baby is on KMC. But yes, surfactant, when we have to give it, at that time the baby is separated from the mother and it is given under the radiant warmer.
Anything from you, Helga? Any difficulty with CPAP? Any challenges?
Initially, it was difficult and the prongs were slipping off the baby's nose. But once we received, we continued to receive training and we managed to secure them safely. It was no longer a problem. Towards the second half of the study, we started giving surfactant and also we had mechanical ventilators. But as Chelani said, during this process, we did it under the radiant warmer. And once the baby required mechanical ventilation, was taken off the mother's chest. But those who required only surfactant, we will give them surfactant. And when they have recovered from the apneas, we will return them back to the mother's CPAP.
Okay. So I will go quickly to the next question, which was on phototherapy. In all the sites, one of the major reasons why they did not get to 24 hours of skin to skin was phototherapy. So there were babies who required phototherapy and they had to be separated for that period while they were getting phototherapy, and that reduced the period of skin to skin contact. However, most babies did not require phototherapy in the first hours of life. And it was only largely, after the first day that some babies required, or many babies required phototherapy. That was the reason why the average was 17 hours. It was 21 hours when we went to the KMC ward. So in the KMC ward, less babies required phototherapy, and other reasons for separation were where the mother was or the surrogate were not available because of some reason, or they needed, if there was only one of them, and they needed something about their own care, grooming, taking a shower, etc. Those were the reasons for separation. There was another question which was on when was KMC initiated, how early is immediate. So the average was about an hour, just less than an hour in all the sites. But it was relatively earlier in some sites and a little bit later in some other sites, depending largely on the availability of the surrogate. And the only delay was when some of the sites like Ghana and Tanzania were finding it harder to find the surrogates. But the average was around 1 hour. We wanted to start it within the first 2 hours of life. The next question is about space. There was a very interesting question that in Sierra Leone or in other sites now, these special newborn care units or special baby care units, SCANUs in Bangladesh, SNCUs in India, are either established or are being established. What should they do? My sense of that I see no reason to build those like the big hospitals, Great Ormond Street or the Harvard Medical School nursery or NICU. There is absolutely no reason. In fact, the smaller places, the district level facilities will do much better if mothers are part of the SNCU. And usually there is not enough pressure on these smaller hospitals or smaller facilities in terms of numbers. If you go to Muhimbili, there will be, in one unit, there will be 100 babies. So there is some pressure of space in bigger hospitals, but in smaller places, I would actually say there is very little. Somebody asked a question about what about babies above 1.8 or 2 kilos for immediate KMC. Our thinking is that we took the less than 1.8 kilos because they are routinely separated from their mothers. They are separated and they are kept in these NICUs away from their mothers, and it is considered to be a justifiable reason to separate them from their mothers. But we do think that there is no reason why bigger babies than 1.8 kilos not benefit from continued skin-to-skin contact all through. And there is evidence from the community KMC study, which was published about a year ago, that babies above 2 kilos had an even larger reduction in mortality. It was a 40% reduction in mortality compared to 30% below 2 kilos. Above 2 kilos, babies were really, it was helping babies survive, but they included only low birth weight babies. The other question, I'm now going down the line. I'm sorry, I'm a little bit slow. The question is why early NMR was not different. We don't think that early NMR was not different. First of all, we think that there was a somewhat equal reduction. But our hypothesis had been that probably there will be an even larger reduction in the first 3 days because we are doing immediate KMC. But as you guys have all seen, the major cause of death that was averted was actually sepsis. And children don't get sepsis within the first 3 days and die within the first 3 days. So usually by the time you start getting sepsis is day 2, day 3, even early onset sepsis, and the deaths happen a few hours or a few days later. So in fact, most of the sepsis deaths don't occur in the first 72 hours. Most of the sepsis deaths occur after. So even though the infection was less likely to happen early, the death may have happened later. So that could be one explanation. Then there is a question on the family-centered care model. And I think that's not a question. Is there a rationale for using the term? We are not talking about the family-centered care or what. Here we are actually turning it. The idea is the same. The idea is that the babies should not be left alone without human contact, human touch for both their survival and developmental care. And Nils, can you just say something more about why you think that this is a biological issue, not just a question of KMC? Why is this early contact important for humans, just like it is for other mammals? Would you like to say a couple of minutes of that while I look for other questions?
Thank you, Rajiv. So purely biologically, primates are carry carers. So the carry comes from maternal carry, and it's contact. Contact isn't kind of care. It's a place where care occurs. And so the place comes with an ecology of sensory inputs. It comes with 30, 40 million years of developmental evolutionary memory, of requirements for optimal transition to extrauterine life, optimal adaptation to the environment, where the mother is providing buffering. These are terminology from developmental neuroscience, but they're expressed intensely and acutely in skin-to-skin contact, where almost certainly maternal smell and all the umbrella of maternal sensations buffer, couch, protect the baby, and provide the immunity. This doesn't quite fit into the picture, but the microbiota is probably even more important and older with respect to these developments. So these are some terms from the science. Will that suffice, Rajiv? I can talk for long, as you know.
No, thank you. I know you can talk for an hour on this. But the idea is that this is something which is so fundamental to mammals, that early contact with their baby, both the mother and her baby, and the early breastfeeding is so important for all babies and mothers. And to deprive low birth weight and preterm babies of this is something that we need to be very careful. And I think this study is showing what that early care does. I have other questions. Nils, I know you want to talk about it. We have 5 minutes left, but 30 seconds. Go ahead.
So this science is about full-term babies. And full-term babies have a little bit of resilience. And therefore, we can separate them and they cope. Premature babies have less resilience. They tolerate separation even less. And therefore, they need, the question about 2,000 gram babies in the chat, premature babies need it much more because they have less resilience and they need more buffering. Thank you.
Thank you. So I have another set of questions. One is on cesarean section. And the question was anesthesia different? No, we didn't change anything. Whatever was being done by the obstetrics team, whatever the mother needed was done. But what is important is just to understand, how did we approach the cesarean section babies? So Helga, would you like to tell us a little bit about how did we approach the cesarean? The mother was obviously not able to come to the MNICU immediately. So what happened? Who provided immediate KMC? What preparations were done? And what was the process? Helga, are you there? If not, Helga can't hear us, then maybe Ebun, over to you.
Okay.
You like to?
So thank you so much. So after cesarean section, usually there's a surrogate, and the mothers will have been counseled antenatally and about the time of delivery, and when to bring somebody along, somebody she trusts that can take care of her baby. And usually that person comes with her, and the person just after the baby is delivered, while the mother is still in the operating theater or is about to be wheeled for one reason or the other to the postnatal ward, the baby is put in the KMC position in the surrogate, and the baby and the surrogate goes to the MNICU. As soon as the mother is able to, come to the transfer to the MNICU, she's transferred there and she takes over the care of the baby. In case there are two babies, then of course a surrogate can continue to stay with her, and he also has a bed and to take care of the other baby. Some mothers were able to take care of the two babies together, depending on their conditions.
Okay, I will go quickly to the other, because I'm aware of time. We have 2 minutes of standard time. I don't know if allow us a couple of minutes extra, but just to answer the questions on role of midwives. We think it is critical. It was very, very important. So can somebody tell us what happened in the labor rooms? So maybe Jikwa, the midwives in the labor room, how were they important? How was IKMC started again with the mother, and their mother was unavailable with the surrogate, but about the mother, what was the role of midwives? Jikwa, are you there?
Yes, I'm here. Sorry, my video. Yes, I'm here. So for the midwives, yes, the midwives were an important part of the team. They were in the labor ward, and as the research assistants were doing the consent taking, it was actually very often it was the midwives to whom the patients would turn. So they would support the research team to explain to the mothers what was going on. We did not initiate the skin to skin in the labor ward. We initiated it when the babies came to the NICU. But the midwives were very important in supporting the mothers to understand what was going on and to explain to them what the IKMC was about. And then when we also have midwives on the NICU, so they were very much involved in all aspects of the study interventions. So they supported the research assistants to initiate the babies in skin to skin and things like that. So they were actually a very important part of the team.
Thank you very much. There are two or three very interesting questions. One is a follow-up on my response to sick newborn care units. And I would like to say again, it's not just the small babies. There is no reason to separate a sick baby from her mother or his mother as well. So if a baby has asphyxia or sepsis, why would you like to definitely separate the baby and the mother to provide care? I still think that a lot of the care can be provided while the mother and baby are not separated. So I would challenge that question, that is this only for the sick babies or only for the small babies? It's for all babies. The BFHI, we essentially wanted to kind of have no separation. And we succeeded for the term healthy babies. But we kept the sick and the small babies as an exception, that it's okay. We are working in their favor. For their best interest, we are separating them from their mothers. Whereas I don't see an iota of evidence that that is necessary, even for the sick babies. So that's my quick response. I have other good questions, so I would continue to do that. Somebody was talking about sepsis. Why a reduction in sepsis? We said several things. Early breastfeeding, earlier breastfeeding, most important thing. Secondly, reduced handling by the nursing and the other staff who were just to change diapers or just to feed the baby. If you have more handling by the health staff, you have more infection. Handling just by the mother, you have less infection. Microbiota, Nils talked about. So if you have the mother's microbiome, which is now causing the colonization of the baby's gut and the baby's skin and the umbilical cord, it is much better than getting it from the NICU microbiota. And one study that we are working on, and Dr. Chalani has some data, is to see if multi-drug resistant organisms are actually lower in the MNICU compared to the NICU without the mothers. And our hypothesis is that probably they are. There is much more resistant organisms in the normal NICUs than there are in MNICUs. So several reasons why infection rates are low. Health workers' role, many people talked about that, and attitudes of health workers. One very interesting thing, not only from this trial, but from the other set of scaling up KMC studies and the community KMC studies that we learned, is usually health workers like to put it on the mothers and families. That, oh, families will not accept this. Oh, this particular culture will not accept this. This particular place will not accept this. It is the other way around. It's the health workers who are the problem and their thoughts, which are the block, not the mothers. We haven't seen anywhere that there is evidence of families not wanting to do kangaroo care. The last question that I will talk about for half a minute is what next? Somebody asked about WHO guidance. So just to let you know, WHO guidelines are under now revision. We will have an independent guideline development group, which will look into the possibility of changing WHO guidelines for KMC come this fall. By November, those guidelines should be available. Many people talked about scale up and whether it is possible to scale up to non-research sites. Our very strong thought is yes. I think the whole panel will agree with me that we think that it is possibly very much scalable, but we will have to learn how to overcome these challenges. We don't want to have a rosy picture that everything you do it like this and it will happen, but it is possible. We are going to do implementation research in many countries to make sure that we understand this and do it well. I'll stop here, hand it back over to you, Olive. And if you want me to share my screen, I will.
Thank you so very much. I first of all have to say that I hope you noted there was so much appreciation in the chat box. Excellent findings, wonderful studies. These findings are very important, and congrats on the fantastic study by the team. And for the webinar today, you know, the content was, this is the best webinar one participant has been at in a long time for content clarity and practical application. So we've gone a little bit over. I'm going to just take 30 seconds to say thank you, Rajiv. Thank you, Harish, Kandwana, Nils, Helga, Yvonne, and Kuku for joining us today, for sharing this rich findings from your study. We will be sharing the recordings and the presentations with everybody through email, and they'll also be on our website. And so we just want to highlight for you that there is a webinar coming up. It's going to address what Niels referred to today as the buffering, you know, the essential nurturing care for every newborn, and to ensure that newborns survive and thrive. That will be on August 25th. So just keep in touch, stay engaged. There's a community of practice being hosted by Save the Children as well on August 4th for World Breastfeeding Week. So all the information is here. We'll share everything with you. Thank you so very much for joining us today.
Thank you, Ali.
Thank you all.
Thank you. Thank you. Thank you.
Thank you
Thank you.
for participating in this discussion, everybody. And thanks to all the panelists for all your work and some beautiful research that you have produced. Thank you.
Thank you, Rajiv.
Thank you.
you.
Thank you, Rajiv, for
Bye.
leading us.
Thank you, Rajiv. Thank you, everybody. Thank you, Nils.
Thank you, everyone.
Thank you. Thank you. Bye.
Well done.
Bye.
This was excellent. Thank you all.
Bye-bye.
Hi, Kujenya.